Your Excellencies, Consuls General of Greece, Mr. Balta, Consul General of Cyprus, Mr. Sofianou, Professor Chiveniak, Professor Hajar, Honorable Guest Professor Anzaklis, distinguished representatives of the Federation of Hellenic Societies, Mr. President of the Papanicolaou Society, Vice President, distinguished colleagues and friends of the Hellenic Medical Society of New York, I welcome you to the 2011 George Papanicolaou Award Symposium, sponsored by Cornell Medical College and the Hellenic Medical Society of New York, and generously and fittingly supported by the Department of Gynecology and Obstetrics of New York Hospital Cornell Medical College. We also acknowledge the valuable support of the Papanicolaou Society, Novo Nordisk Company, Merck Pharmaceuticals, and Warner Chilcott Company for this evening's event. Tonight we honor the memory of Dr. George Papanicolaou, a founder of our medical society, actually not 1936 but 1918 that he had his initial concept, and in profound gratitude for the distinction to Hellenism afforded by his legacy. In the words of our past president departed, Dr. Theophilos Diligianidis, chair of the committee which established the Papanicolaou memorial events and commissioned his two busts, which grace both Cornell University and his alma mater, the University of Athens class of 1904, Dr. Pap's work belongs to humanity, and his discoveries constitute a free gift to mankind. Dr. Papanicolaou was proposed twice for the Nobel Prize. In 1953, Professor Gregory Kaltsas proposed him, and in 1959 by Professor Hammerich von Hamm. The American government was also petitioned twice, President Reagan and President Clinton, for the Medal of Freedom to be awarded posthumously. It is my belief that the sincere gratitude of millions of women, the profound appreciation of the entire medical profession, and the reverence accorded his name by his country of origin, and all Hellenes, form the laurel wreath that dwarfs any other distinction which organizations and governments can deliver and should have delivered and did not deliver. Thank you. And at this point, I would like to invite, I think from the Federation of Hellenic Societies, Dr. Frixos Gousis is representing, and would like to say a few words.
Thank you, Nikos. Good evening, everyone. Your Excellencies, Ambassadors of Cyprus and Greece, honorees, Professor Anzaklis and Hajar. I want to congratulate, dear colleagues, and every one of you. I would like to congratulate Dr. Mizidis and the Hellenic Medical Society for this extraordinary event. I would also like to acknowledge and thank the Vice President, Mr. Ringos, of the Papanicolaou Society and the Federation of Hellenic Societies of New York and its President, Mr. Tsikeridis. All of you, all of them have sponsored this significant event. I'm here with a dual citizenship, not as a Greek American, but a dual capacity as a long-standing member of the society and member of the professional representation team, and also as a chairman of the public relations of the committee of the Federation of the Hellenic Societies. On behalf of this federation and its entire executive board, we are looking forward for a continuous and productive cooperation and sponsorship of similar scientific as well cultural and social events for the benefit of the Hellenics abroad and the American community at large. Dr. Papanicolaou is an unparalleled, incomparable, historic and scientific figure in medicine. He has offered his time, knowledge, brilliance, and exemplification of what a great physician and a human being can genuinely aspire towards and actually reach that summit. We all should seek to aspire to achieve excellence in our profession, to help others in all possible ways, and to join in the discourse of social, medical, and humanitarian causes which merit our involvement and our focus. Thank you.
And I would like to invite Mr. Tassos Rinkos, Vice President of the Papanicolaou Society, where Dr. Papanicolaou hailed from Libya. Kimi.
Thank you, Dr. Mazidis, esteemed guests from the Cypriot and Greek Embassy, ladies and gentlemen. I am here to give just a brief bio of Dr. Papanicolaou, speaking on behalf of the Papanicolaou Society. We are especially proud of the man we honor today, a man of vision who contributed so greatly to women's health to this very day. Dr. George Papanicolaou was born in Kimi, a town on the island of Evia, Greece, on May 13, 1883. After he completed elementary school in Kimi, his father, Dr. Nicholas Papanicolaou, who was a medical doctor in Kimi, sent him to high school in Athens. After high school, he attended the University of Athens and studied languages, philosophy, and music. He graduated at the age of 21 and then attended the Medical School of Athens. Dr. Papanicolaou returned to Kimi with a medical degree, did not want to practice medicine. According to the biographer Demosthenes Triandafilou, Dr. Papanicolaou had a passion to achieve something unique. He told his father, "What is the meaning of life? To work in an office and make money, or to work in a research center and become immortal?" So he rebelled against his father. But his father didn't hold it against him. Instead, he sent him to Germany, the intellectual center at the time for postgraduate studies. Dr. Papanicolaou obtained his doctoral degree in zoology at the University of Munich. During his time in Germany, Dr. Papanicolaou's quest and self-searching intensified. Meanwhile, back in Kimi, his father still had hopes for him to return to practice medicine, like all our mothers and fathers. He wrote a letter to his father saying, "For me to come and lay myself in that environment without research is suicide. I can never do that, even if I have to disobey you." Eventually, though, he did return to Kimi and married Mahi, also known as Mary Mavroyeni. Since there were few professional options available in Greece, he left, first going to France, where he worked as a physiologist, and from there he returned to Greece to fight in the Balkan Wars of 1912. While serving in the Greek army, he met Greek-American volunteers who told him about the vast opportunities that America had to offer. Finally, he came to the United States in 1913. Life in America was difficult for him due to the economic conditions at that time. He was selling carpets and his wife was stitching buttons at Gimbel's for $5 a week. He also played the violin at restaurants at night. In 1914, he started working here at Cornell University for almost 50 years. He worked 6 and sometimes 7 days a week. His wife, Mary, was always by his side. She was his lifelong partner and research assistant, becoming proficient as a technician in her own right. It was at Cornell University where Dr. Papanicolaou worked examining vaginal smears of guinea pigs to determine the existence of a menstrual cycle. Eventually, Dr. Papanicolaou became interested in the menstrual cycle of women. In 1923, Dr. Papanicolaou told an audience of physicians about the technique of gathering cellular debris from the lining of the vaginal tract and smearing it on a glass slide for microscopic examination as a way to identify cervical cancer. That year, he had undertaken a study of vaginal fluid in women in hopes of observing cellular changes over the course of a menstrual cycle. In female guinea pigs, Dr. Papanicolaou had already noticed cell transformation and wanted to corroborate the phenomenon in human females. It happened that one of Papanicolaou's human subjects was suffering from uterine cancer. Upon examination of a slide made from a smear of the patient's vaginal fluid, Dr. Papanicolaou discovered that abnormal cancer cells could be plainly observed under a microscope. The first observation of cancer cells in the smear of uterine cervix. At a 1928 medical conference in Battle Creek, Michigan, Dr. Papanicolaou introduced his low-cost, easily performed screening test for early detection of the cancerous and precancerous cells. However, this potential medical breakthrough was initially met with skepticism and resistance from the scientific community. And it was not until the early 1950s that large-scale screening using the famous Pap smear began. This resulted in a historic drop in the incidence of cervical cancer among American women. Dr. Papanicolaou died on February 18, 1962, at the age of 79, and he is buried in New Jersey. Throughout the years, millions of women have received the Pap test. Because of this test, deaths from uterine cancer have greatly reduced. Dr. Papanicolaou gave and continues to give life to women throughout the world because of his great work. Thank you.
I'd like to invite the chairman of the Department of Gynecology Obstetrics at Cornell Medical College, Professor Cheverniak, to introduce our speaker for this evening.
Leaders from Greece and Cyprus, Nick, Spiros, Aris, Kathy, members of the Hellenic Society of New York, the Papanicolaou Society, many friends, old and new. It's a pleasure and privilege to be here tonight. Our Department of Obstetrics and Gynecology is truly an international one, much more so than other departments in this country. We're involved in many, many international activities. As a result, we have many international visitors. And there is nothing that gives us a sense of pride more than when I have our international visitors and we show them the statue of George Papanicolaou, because it represents the best in what medicine is. And I think the descriptions that we've just heard of what he contributed to medicine and what he gave of himself through his tireless efforts, I think have said beautifully. I have to admit that our department 50 years ago was not what it was today, and our gynecologist originally gave him a little bit of trouble and didn't accept initially his brilliant advice. I want to believe that our gynecologist today, I see Dr. Caputo on the back, would hopefully agree that would be a little more receptive to his advances right now. Talking to Spiros, we thought, what is the best way to honor this great man who brought screening out of the Dark Ages into the modern time? And the best way to honor this great man is with the living legacy of Arisensaklis. Arisensaklis was born in Kalimbata, Greece, not too many years ago. And he received his training in Athens. Being a true citizen of the world, he complemented his training at the great centers, at University College in London, at Yale New Haven Medical Center. He then spent the bulk of his career in Greece and was and is renowned as a great clinician. I think anyone who is well known knows Aris Sansaklis and has been cared for Aris, either for the screening, for the ultrasound, or for their pregnancy. He introduced invasive testing and basic ultrasound in Greece and elevated the whole standard of care in Greece and elevated education in Greece in obstetrics and gynecology. And indeed, the position he now serves illustrates that beautifully. He is professor and chairman of the Department of Obstetrics and Gynecology at the University of Athens. But Aris's reach goes far, far beyond Greece. Aris has served as president of the European Association of Perinatal Medicine, vice president of the International Academy of Perinatal Medicine, on the board of the Donald Inter-University School of Ultrasound, the International Society of Fetuses Patient, vice president of the World Association of Perinatal Medicine. I have it on good authority. He's likely the next president of the World Association of Perinatal Medicine. I think it can be a fair statement that it's not just myself, to use a word that's sometimes overstated, that Aris has earned the trust of not just myself, but colleagues from throughout the world. Is a wise man that people go to for advice, not just in Greece, but whether in New York or throughout the world. He has a wisdom that people want to be with, and I think you'll be convinced by the end of his lecture that I'm not overstating the case. I'm delighted to present to you Aris Sansaklis.
Frank, thank you very much for your very kind introduction. Thank you very much. So, Ms. Chancellor of Cyprus from Greece, Ms. Chancellor from Greece, Dr. Mezitis, President of Hellenic Medical Society of New York, Mr. Ringos, Vice President of Papanicolaou Society of the United States, also the President of the Federation of Hellenic Societies of Greater New York. I would like to thank you, all of you, for the kind invitation and also the nomination to take the award for George Papanicolaou 2011. My presentation today is going to be approximately 20 minutes, maybe less. And I'm going to talk about screening in obstetrics and gynecology. Since Papanicolaou, as we heard, is the first scientist involving with screening, and especially in obstetrics and gynecology, I thought that it's a very good idea to speak about and talk about screening in obstetrics and gynecology. Screening, ladies and gentlemen, refers to test for the detection of the individuals at increased risk for a particular disorder. And screen tests have to be simple and easy, has to be effective, profitable, to be free of undesirable and deleterious effects, and to be comfortable, least aggressive or painful to the patient. It is important that the screening test be cost-effective, and this implies that the disorder is of high prevalence and that the result improves the outcome. This is a term for a screening test, because screening without any demonstrable benefits wastes resources and makes no difference in the health population. So we have to be very careful when we say screening. What screening exactly meaning? Concerning the gynecology, when we say screening in gynecology, these days we screen for cervical cancer, we screen for endometrial cancer, we screen for ovarian cancer, and we screen for breast cancer. I'm not going to go through all this screening because it takes about 5 hours to say exactly what screening for these diseases means. So I'm going to stay only for cervical cancer and breast cancer. And I'll tell you why. Because cervical cancer is the most adequately studied cancer in human. It's the second most common gynecological cancer after breast cancer. It's the second leading cause of death in young women in Western countries. It's the first leading cause of death in women in the third world. It's a serious health problem which should be eliminated through screening policies. And ladies and gentlemen, screening can detect cervical cancer at an earlier stage before symptoms are evident, when treatment is more effective. And in addition to screening, to detecting cancer early, screening for cervical cancer can identify and remove precancerous abnormalities, preventing cancer altogether. This man is the pioneer of screening, and especially screening of sex and gynecology, and special screening in gynecology. His name is Georgios Nicholas Papanicolaou with K, or George Papanicolaou with C. In Greek is Georgios Papanicolaou, as everybody knows, and born 1883, died 1962, age 78. I'm going to go very quickly because you heard from Mr. Ringos before about Papanicolaou, but I want to tell you that he finished medical school in 1904. He went to, as you heard, in Munich. 1913, emigrated to the United States in order to work in the Department of Pathology of New York Hospital and the Department of Anatomy at the Weill Medical College of Cornell University. 28, he first reported that uterine cancer could be diagnosed by means of a vaginal smear. 1943, recognition of his work through the publication, together with Herbert Roth, of diagnosis of uterine cancer by the vaginal smear, and he thus became known for his invention of the Papanicolaou test, commonly known as the Pap smear or Pap test, which is used worldwide for the detection and prevention of cervical cancer and other cytologic diseases of the female reproductive system. 1950, received Albert Lasker Award. In 1961, he moved to Miami, Florida, to develop and to found the Papanicolaou Cancer Research Institute at the University of Miami, but died in 1962 prior to its opening. I don't know if this center exists. So, Pap test has been so successful all these years that it has been hardly changed for over half a century. Since then, there are not so many changes. Pap test is what some refer to as a predominating technology. And if you see today how things are in screening, HPV vaccine appears to be another predominating technology with respect to cervical cancer prevention. So I had to go through 50 years to make a new change after what Papanicolaou found the Pap test, the Pap smear. And what is the impact of cervical cancer cytology in the United States, for instance? You see, in 1950, prior to the widespread screening using the Pap test, the incidence of cervical cancer in the United States was between 30 to 40 cases per 100,000 women annually. Then started the pap test, and in 40 years there is a 75% reduction of new cases, and now in 1990 there were only 10 cases per 100,000 women. This is a major success story of cancer prevention using the pap test. And if you see this slide, is the difference in incidence of cervical cancer between countries with routine mass screening and those with no routine organized screening. And you see that in Brazil, without any screening, there is absolutely difference with what happened in England. And you see that the cases, the incidence per 100,000 women is increasing in Brazil without any screening. And in United Kingdom stays stable the last 50 years. But even when in a system that there is a system, organized screening system, there is approximately 20% of the cases that you cannot detect with a pap smear. You see in different countries in Europe that in Denmark, for instance, the incidence of new cases is reduced. They do have a screening program. In Poland, they don't have a screening program. In Spain, that they don't have a screening program, you see an increase in incidence of cervical cancer, and in the United Kingdom there is a reduction of cervical cancers because they do have a very good screening program. So well-organized population-based screening programs have shown a progressive decrease in both the age-adjusted disease incidence and mortality rates for cervical cancer in the developing countries. And what we mean with the population-based screening programs, that means that there is an introduction of a computerized recall system, new quality standards, and new guidelines for the follow-up of women with abnormal smears. If you do have this program, and if it works, this program, you have a reduction in new cases. What happened in Greece? In Greece, ladies and gentlemen, unfortunately, there is no national program. Only less than 20% of population is performing routinely pap test. And I'll tell you what, there are women that they're overdoing pap smear. They're doing 3 times a year. And there are women that they perform a pap smear every 5 years. We forget, because we don't have a recall system, which means national program. So in this case, there is no significant change in the incidence of the mortality and the mortality rates because of cervical cancer. The second biggest disease, cancer in women, is the breast cancer. It's the most common, is the second leading cause of death for cancer. As a screening, you can use monthly breast self-examination, annually clinical breast examination, and mammography. In women more than 40, they have to perform a mammography annually. Presymptomatic detection of breast cancer is associated with a reduction in the risk of dying from breast cancer, less aggressive surgery, less aggressive adjuvant therapy, a greater range of treatment options. And also, are there any limitations because from mammography? Yes, there are. We will not detect all breast cancer. Some cancers detected with mammography may still have poor prognosis, potential false positive results, some of which may not be resolved with additional imaging, and that if not, a biopsy will be required to rule out the possibility of breast cancer. In high-risk cases, in women they do have relatives with breast cancer, they have to perform annually screening mammography and also MRI starting at the age of 30. And ladies and gentlemen, since our specialty is obstetrics and gynecology, I'm going to go through very quickly through screening in obstetrics, and especially screening with ultrasound in obstetrics. You know that there are three major how can I say anakalypsis? Discoveries in obstetrics. Three. There are ultrasound, ultrasound, and ultrasound. Ultrasound is the most important technology developed for aiding clinical management of pregnancy and is widely accepted by parents, by women, and by fetuses. And also women consider the use of ultrasound as a barometer for adequacy of maternal care. Women, they used to come to their doctors and say, are you going to perform an ultrasound to see the baby? Every time, in every visit. I don't know if this is correct or not, but it's screening. So ladies and gentlemen, we screen for everything in obstetrics. We screen for chromosomal abnormalities, we screen for fetal malformations, we screen for preterm labor, we screen for preeclampsia, we screen for reduction in perinatal mortality and morbidity. We screen for everything using ultrasound. And the objectives for routine ultrasound screening for fetal malformation are two things: to estimate the sensitivity of ultrasound and also to estimate the benefit of ultrasound. And the question is, does routine ultrasound improve the overall perinatal mortality and morbidity? It's worthwhile to perform an ultrasound in women they don't have any problems. So when ultrasound offered to an unselected population, it's being used as a screening test. And pregnancy, normal pregnancy, is an unselected patient, pregnant women. Screening refers to test for the detection of individual at increased risk for a particular disorder. And since screening tests are only concerning with likelihood, they have false positive and false negative. And this is very important also, false positive and false negative. The major risk is maldiagnosis. Error can be corrected if there is a false positive for a malformation. If you perform an ultrasound and say, okay, the baby has a problem, error can be corrected in a tertiary referral center, but there is also the false negative misdiagnosis that is undetected unless there is a second examination. The risk of misdiagnosis is real and difficult to overcome. So misdiagnosis in cases you do have an ultrasound examination is very important. There are some questions. How good are ultrasound in yielding the required information? How useful is to obtain information? Can anything be done to improve the outcome? Does the evidence support the use of routine ultrasound scanning of all pregnant women rather than those with clinical indication? So, do we have to offer screening with ultrasound in women they don't have any problems? And I have to tell you that most of the pregnant women, they don't have problems. During the first trimester of pregnancy, the 3 first months, we screen for all this, and I put with red, we screen for malformations and we screen for aneuploidy, for Down syndrome and all the chromosomal disorders. And I'm going to go a little bit fast. New trends is the full scan of fetal anatomy for the first trimester of pregnancy, first trimester detection of congenital malformation, and evaluation of nuchal translucency thickness, or the nasal bone for defining the risk group of fetal aneuploidy. You see here the nuchal translucency. The nuchal translucency is this area over there. measured by trained sonographers between 11 and 14 weeks combined with maternal age, detection rate 77% with a false positive rate 5%, fetus with Down syndrome. Also, in cases you do have an increased nuchal translucency with a normal karyotype, let's say the fetus is not Down, is associated with high prevalence of carotid defects. Also, abnormal ductus venosus flow, characterized by absent or reversal of flow, was found 90.5% of chromosomally abnormal cases and in 3.1% in chromosomally normal fetuses. So, has been decided that Doppler studies to be carried out before CVS to reduce the number of invasive procedures. The nasal bone is the bone over there. Between 11 and 14 weeks, nasal bone is not visualized sonographically in 70% of fetuses with Down syndrome and in 1% of haploid fetuses. Also, if you combine nuchal translucency with nasal bone, you increase your detection rate up to 90% with a false positive. And if you put all together about screening for chromosomal defects, you see, if you start with a maternal age, say that if you are over 35, you have to perform an amniocentesis because you have an increased risk of having a baby with Down syndrome. Your detection rate is 30% if you use maternal age, and you increase your detection rate with the same false positive rate up to 97% if you combine maternal age, nuchal translucency, nasal bone, beta SCG, Papae between 11 and 14 weeks of pregnancy. But first trimester ultrasound examination has become more comprehensive, and obstetricians have learned to examine the fetus in a greater detail. And you see that you can have a full anatomy scan between 11 to 14 weeks in 60%, 68% in early pregnancy. And if you combine the first with the second trimester, you increase your detection rate up to 85%. We performed a study in Alexandra Maternity Hospital in the first department of OBGYN in the University of Athens. We assessed the fetal anatomy at the 11-14 weeks ultrasound with an ultrasound examination, and we had approximately 1,200 fetuses, and the conclusion was that the examination of fetal anatomy, including the heart, is visible at the routine ultrasound scan between 11 to 14 weeks. Completeness of examination depends on maternal habitus and gestation. Optimal gestation beginning of 12 to the end of 13 weeks. Access to transvaginal scan essential in completing the examination. And 14-11 weeks scan will become the first anatomy scan of the fetus. That means that you don't have to wait up to second trimester of pregnancy in order to pick up malformations. You can perform that in a screening way, in performing an ultrasound during the first trimester of pregnancy, and you can pick up to 86% of fetal malformations. First trimester cannot substitute the second trimester scan, and we can during the second trimester what we scan. And ladies and gentlemen, again, we scan everything during the second trimester. We scan for aneuploidy, we scan for malformations, but we scan also for premature labor, and we scan also for preeclampsia. The genetic second trimester sonography represents a group of sonographic findings which can be integrated to a score of relative risk assessment to determine the odds that a specific fetus has Down syndrome. That means that we can perform an ultrasound examination, and there are some special signs that we can take it and we can put in a score in order to say the possibility, the likelihood of having a baby with Down syndrome. And these are some major and minor structural anomalies or some non-structural abnormalities of, as we call, the soft markers. And the structural anomalies associated with fetal chromosomal abnormalities are these that you see here in this slide. And also, there is a strong association between gross sonographic defects and chromosomal abnormalities, which are these: cardiac, kystic groma, non-immune hydrops, renal abnormalities, duodenal atresia. And I come to this slide, which is very important. There is a very good correlation between congenital heart defects and chromosomal abnormalities. And you see that 99% of newborns with trisomy 18, they do have congenital heart defects. 90% of newborns with trisomy 13, they have congenital heart defects. And half of the newborns with Down syndrome, they do have congenital heart defects. So, if you perform an ultrasound and the fetus has not any cardiac defects, you eliminate the risk of having a baby with trisomy 18 or 13, and also you reduce by 50% the risk of having a baby with trisomy 21. Here are some non-structural abnormalities, the soft markers are we call. I'm not going to go through all this. And I can tell you that there are different scores, but they have the possibilities and the likelihood of having a baby with aneuploidy. And you see, if you put a score to different soft markers, as we call, there is a likelihood ratio up to 25. So the most dangerous thing to have is the major structural anomalies. If you do have a baby with structural anomalies, you have a greater possibility of having a baby with aneuploidy. So we screen for preeclampsia, and you see that the sensitivity for all preeclampsia is 40%, and this increased to 80% for preeclampsia requiring delivery before 34 weeks if there is an impedance to flow at 23 weeks of gestation. Also, we had again a study in Athens about this, and I come to the next, which is the screen for preterm. And we know that preterm birth is the leading cause of neonatal mortality and morbidity, occurs 10% of pregnancies. In the last 15 years, the incidence is exactly the same. And also there is a relationship established between cervical length, funneling, and the risk of preterm labor. But the etiology of preterm birth is multifactorial, and one of the causes is cervical incompetence. And if you measure the cervical length by transvaginal ultrasonography between 14 and 24 weeks, as a screening, if you use these measurements as a screen to identify patients at risk for preterm delivery in the general population. So you see that we screen for all in obstetrics. But what we saw is that routine ultrasound screening does not alter perinatal outcome except for lowering perinatal mortality as a result of induced abortions following the detection of abnormalities. What that means that the only good thing is that we can pick up some malformations, and we can stop these pregnancies so we don't add these malformed neonates in the cases of perinatal mortality and perinatal morbidity. There are two studies, one from the United States, the RADIUS study, and there are two studies in Europe, old studies. I'm going to go through the Eurofetus, which is a study for the assessment of efficacy of ultrasound in detecting fetal malformation in a mass screening program. And what is be shown that the sensitivity of ultrasonography screening for malformed fetuses is 61%, higher for fetuses with several malformations, lower for fetuses with a single malformation. And in 4,000 congenital anomalies, we had 38% major congenital anomalies and 63% minor congenital anomalies. But 1/4 of the abnormal fetuses have more than one malformation. So when you screen and you find a malformation, try to find another one. And you see that 79% they had a single, but 21% of the cases they had 2 or more malformations. And also, the major congenital anomalies, the sensitivity was 88% for the malformations of central nervous system, goes down to 39% for the cardiovascular system, and also the sensitivity for the ultrasound in pickup minor congenital anomalies were 90% for the urinary tract and 18% for skeletal system. Of course, there are some gestation age is increasing the sensitivity, also with the indication of sonography is increased, with the experience of the examiner is increased the sensitivity of ultrasound. So to finish is that patients undergoing an ultrasound for an anatomic survey should be provided with several informations. And this information is the explanation regarding the differences between screening and diagnosis. Screening is absolutely different than diagnosis. That 2 to 3% baseline ratio of major anomalies. Third, the limitation of screening, the possible results, the implications of these results, and also information that 1/3 of major anomalies cannot be detected. And when you perform an ultrasound examination, you have to counsel the patient in that way, that there is a 2 to 3% baseline ratio of major anomalies, and also there is information that 1/3 of major anomalies cannot be detected by an ultrasound. Ultrasound, targeted sonography should be performed only by those physicians with training and experience in the diagnosis of congenital anomalies, and there is no evidence that routine ultrasound will change the overall pregnancy outcome of a population of a low risk. And with that, I would like to finish, and I would like to thank you. I would like to thank you very much for your I can tell you I feel very honorable for this award, and I would like to thank you, all of you in Greece. You remember different things of Greece, and also maybe you can come this September in our meeting we have in Athens. Thank you very much.
And now I would like to invite our next speaker, a good friend of our society, who's also been with us in the past. This will be Professor Catherine Hajar, Professor and Chairman of Anatomy and Cell Biology at Weill Cornell Medical College. Professor Hajar.
Well, thank you very much. I'd like to say that our representatives from the consulates of Greece and Cyprus, our leaders of this great society, the Hellenic Medical Society, the Papanicolaou Society, all of our distinguished guests and colleagues, that I'm very honored to be here tonight and to tell you a little bit about the work that some of us are doing in the Department of Cell and Developmental Biology. Dr. Papanicolaou was a member of our department before my time, but I think his legacy lives on. I think he was one who believed in the value of basic science for medicine, and that's really what our department is all about. So, if I can... So, what I would like to tell you about very briefly tonight is some work that we've been doing on the retina in the eye, some work on ischemic angiogenesis, so the abnormal formation of blood vessels in the eye, and some new insights, no pun intended, that we've gotten from studying a protein called annexin A2. And all of this concerns a problem that is not too distant from the previous talk where we heard about screening in obstetrics. Now we're talking about the newborn and a disorder called retinopathy of prematurity. This is a problem that's well known to pediatricians as well as to obstetricians, and it is in fact the #1 cause of visual impairment in children in the developed world. This is a problem that affects preterm and low birth weight infants. It involves loss of blood vessels within the retina when the babies are treated with high levels of oxygen, a process called vasoobliteration. And this phase is followed by a different phase in which there is a reactive proliferation of blood vessels once the child is taken off of oxygen and returned to room air. All of this is directed by an overproduction of growth factors that stimulate angiogenesis, in particular this one here, VEGF, or vascular endothelial cell growth factor. And when we get this proliferation of blood vessels, they begin to invade from the retina actually into the vitreous space in the eye. They can cause bleeding and scarring of the retina, traction of the retina, and even ultimately detachment of the retina. And that's the usual cause of blindness in this problem. So if we have the retina of a healthy infant, most of the blood vessels, if this is a preterm infant, are formed, perhaps not completely reaching from the optic disc to the periphery of the retina. But over time, these vessels grow out and eventually cover the entire retina. If we have a sick infant, on the other hand, an infant who requires oxygen for lung disease or sepsis or asphyxia, then the story can be very different. During the time that the infant is exposed to high levels of oxygen, we have an obliteration of blood vessels in the central part of the retina. And then when the infant returns to room air, there is a relative ischemia in the central part of the retina, and we get a very vigorous and robust proliferation of blood vessels in the edges or the peripheral parts of the retina. And this is the problem that causes the visual difficulties. So here is an example of a normal fundus or retina from a normal patient, and over here we have an example of retinopathy of prematurity. And what's happening here is that we have abnormal vascularization of the retina. There's some areas of hemorrhage shown here near the asterisk. And then there is also a peripheral avascular zone shown by the arrows. And this retina may actually detach and scar down and just form a fibrous ball in the center of the eye. Histologically, what happens is that if we look at the surface of the retina here, extending out beyond it are all of these proliferating blood vessels. This is actually in the vitreous space. And this is a special stain that just marks new blood vessels, the GLUT1 stain, showing again that we have these vessels invading the vitreous of the eye. What we've done is to use a mouse model to study this process. And the mouse is a very convenient model because in contrast to the human, the vasculature of the retina, as shown here, develops postnatally in the mouse. So at birth, there are just a few blood vessels emanating from the optic disc. These proliferate and grow out, and by 7 days of age, the newborn mouse has a fairly complete set of blood vessels in the retina. So what we can do is we can take a mother mouse and her babies and place them in a chamber where we deliver 75% oxygen. So this is 3 or 4 times the normal concentration of oxygen in room air. And then after 5 days, from day 7 to day 12, we return the mother and the babies to room air, into a normal cage. And we can compare these baby mice to mice that are maintained in room air throughout the entire 2-week period. And then we can look at the retinas of these baby mice and see what happens. And what we typically see, here's a section through the retina of a mouse that was exposed only to room air. You can see that the membrane here that demarcates the vitreous is complete and not breached by any blood vessels. On the other hand, in the mice that are exposed to high oxygen, we see there are these little vascular tufts that now protrude out from the retina and enter the vitreous space. And here's a higher power view of one of these abnormal angiogenic vascular tufts. So in our research group, we've been interested in a protein called annexin A2. This is what it looks like in a cartoon. And this is a protein that's expressed on endothelial cells, the cells that form new blood vessels, normally and under pathologic conditions. An interesting property of this protein is that it binds two other proteins that are part of the fibrinolytic system in the blood, the system that breaks down fibrin and lyses blood clots. And actually, the annexin A2 is a member of a very large family of proteins, all called the annexins, that are present in all eukaryotes, from the simplest single-cell organisms and plants all the way up through the mammals. And in humans, there are 12 different annexins, most of whom have a function that is still unknown. This protein, annexin 2, also interacts with another protein called P11 that I won't be talking about in very much detail, but they work together, and annexin 2 forms a complex with P11 such that we have now 4 molecules together, 2 copies of A2 and 2 copies of P11. And as I mentioned, this complex binds tissue plasminogen activator and plasminogen and generates plasmin, which can then help to degrade fibrin when it shouldn't be around. And so what we think is that first, the classical view of fibrinolysis is that you have fibrin, and the fibrin binds plasminogen and TPA. There may also be urokinase around. Plasminogen is activated to plasmin, and then plasmin breaks up fibrin or lyses the thrombus or the clot. What we've come to appreciate over the past several years is that this system also can work on the surface of cells. And if we have the annexin 2 P11 complex, it also can bind TPA and plasminogen. There's also the urokinase, which has its own receptor. But suffice to say that when this assembly occurs, we form plasmin on the surface of the endothelial cell, and this plasmin can then degrade fibrin. And we think that this is an important process that allows endothelial cells to make their way through fibrin and begin to form new blood vessels. Formation of new blood vessels can be good if you have a problem with wound healing, for example, but it can be bad if we're talking about angiogenesis in the eye. So, what have we found? Well, first of all, we began to look at the expression of annexin 2 in blood vessels in the eye. This is a cross-section through the retina. Here's the vitreous up here. The scleral surface is down in this region. And on the surface of the retina, if we look at a mouse that has only been exposed to room air, we see a few blood vessels, the green staining, and some expression of annexin 2, the red staining, and they colocalize most of the time. But if we look at the retina from a mouse that's been treated with high oxygen and then quickly returned to room air, we see that there is a very robust increase in expression of annexin 2, that's the red staining, an increase in the number of endothelial cells, that's the green staining, and that these are localized in the same relative region on the surface of the retina. So expression of annexin A2 is increased during this model of retinopathy of prematurity. We've also looked at this a little more quantitatively, and we've now begun using annexin 2 knockout mice. These are mice that have no annexin 2 because the gene has been deleted. And what we find is that if we look at the retinas, these are en face preparations of retina, so we're looking down on the retinal surface. We can outline the area of vasoobliteration in yellow, and here there's no difference between the normal mouse, the wild type, and the knockout. But if we look at the area of neovascularization, the number of new blood vessels, it's greatly reduced in the knockout mouse, and here's some quantitation of that. So there's less than 50% the usual number of abnormal blood vessels in the knockout mouse. And here's a cross-section through the retina, and again, I think you can appreciate that there are fewer green spots here than in the control. This is, again, the knockout mouse that shows a loss of abnormal vascular development by about 50%. So this suggests that this protein annexin 2 is required for this abnormal vascular response that leads to problems in the newborn. We found also that we could restore the vascular response if we gave back annexin 2 using a replication deficient virus. So here is the knockout retina showing very little neovascularization. Here's a huge increase that we see when we use the annexin 2 expressing virus to give it back to the knockout. And there's over here an increase in the total amount of neovascularization when we quantify it. We can see the same thing here in the cross-section. Here's the retina that from the knockout mouse, very little neovascularization, and then a significant increase when we give back A2 using this virus. So how would annexin 2 be promoting this neovascular response? Well, we thought we would look at fibrin because we know that fibrin is the main substrate of plasmin, and we know that annexin 2 helps to make plasmin. So we stained for fibrin. Simple experiment. These are wild-type animals. These are knockouts exposed to oxygen. And what we see is that in the wild type, there's very little fibrin that would stain in red in the normal retina. But when we look at the knockout, we see increase in fibrin staining, and a little bit more evident here in the higher power view. So fibrin is accumulating wherever the vessels are not forming. And again, if we give back annexin 2 using a virus that expresses it, then we see that all this fibrin that was accumulating up here has now disappeared. So annexin 2 leads to the disappearance of fibrin. And so maybe by degrading fibrin and getting rid of it, annexin 2 contributes to this robust angiogenic response. To test that idea, we did another experiment where we treated mice with a drug called Ancrod. And what Ancrod does is to deplete fibrin. It depletes the precursor of fibrin called fibrinogen. And so these mice are unable to make substantial amounts of fibrin. And if we then expose our knockout mice to oxygen, again, we see fibrin accumulating within the retina and not much vascular response. But if we treat the animal first with Ancrod, now we see robust angiogenesis, all of this green staining, and the fibrin has disappeared. And you can see that down here. The Ancrod causes a big increase in neovascularization compared to the untreated control animal. And then finally, we did the sort of opposite experiment where we inhibited fibrinolysis using a drug called tranexamic acid. So here we have a wild-type animal exposed to oxygen, significant neovascularization of the retina, no fibrin. If we then inhibit the fibrinolytic system, fibrin, of course, comes back, and in response to that, very little vascular development in response to oxygen. And so here we can see the same thing, the tranexamic acid causing an increase in fibrin deposition decreases the total amount of neovascularization. And so just to conclude, I would say that retinopathy of prematurity, again, is the #1 cause of blindness in children in the developed world. And our results would suggest that annexin A2 is required for the development of this disease, at least in a mouse model. Secondly, that this protein annexin 2 may facilitate neovascularization of the retina, perhaps by promoting the degradation of fibrin surrounding the blood vessel. Fibrin perhaps acting as a barrier to these neovascular cells that are trying to form new blood vessels. And all of this suggests that one might be able to treat this disease perhaps by inhibiting the fibrinolytic system, at least locally in the retina, during a specific time frame. So I'd like to end it just by saying that it was Dr. Papanicolaou who said the following: one should not lose sight of the all-important role of basic research in opening new and ever-widening avenues of investigation for the advancement of science and the benefit of mankind. And so in our department, we are trying to do science for medicine, and one never knows, but we hope that some of this will have usefulness for patients in the future. Finally, just to thank the members of our lab, and in particular, I would highlight Bi-Hui Huang, who's a graduate student. This was his graduate thesis project, and he'll be receiving his PhD in just about 10 days from now. So, thank you very much.
Thank you, Dr. Ajjar. It's good to see that Dr. Papanicolaou's legacy is alive and well. It's also beautiful to see the vindication of the scientific method in posing the question and then very, very elegantly proceeding through the steps methodically to answer, to provide the answers. And looking at the cytology also was an opportunity, almost like looking at beautiful flowers, just to see this exposition of these retinas and everything else. So congratulations, Dr. John, on your work, and thank you very much. At this point, I would like to invite Professor Chereniak to join me here. I'd like also to invite Dr. Spiros Medidis of the Federation of Hellenic Medical Societies, who was instrumental in organizing this evening's event with Professor Chereniak. And we'll also like to present our award to Professor Anzaklis. I'd like to invite him to join us. So
Thank you very much.
this is the award of our department. Congratulations. Thank you very much for joining us this evening. It's very important. Now, I would also like to invite, well, I don't know, I think the Papanicolaou's representative has left us. Is there someone from the Papanicolaou's? Oh, he's here? He's here, yes. Please, join us. And the president? Could you kindly join us for the award?
Thank you.
Dr. John, can you also join us for some of the please?
Thank you.
Thank you very much.
Let's keep the box. Keep the box. Only down here.